So now I think we will start our panel 2. And then for panel 2, the focus is on key theoretical, methodological, and ethical issues in health communication. And then actually, Jeff and Kevin and Emily, they mentioned, some of, the aspects. Okay, so then, but anyway, this should be the panel that, we talk more in depth, okay, about these issues. And then therefore, in this panel, we are very, very honored to have 3 distinguished guest speakers. We have Professor Terry Thompson, we have Professor Sandy Smith, and then we have Professor Mohan Datta. And all 3 of them, they are very, very well-established scholars in the field of health communication. If I have to, talk about their achievement, I may have to use all 90 minutes. And then therefore, that is totally undoable. However, I think, I should still provide a very, short, introduction about each of these distinguished scholars. So just let me try to finish that within 10 seconds. But then if you, of course, if you want to know more about their achievement, please Google them, okay? And then you will be able to, find, information, but then be careful with disinformation and misinformation online. Okay, so Professor Terry Thompson, she is Professor Emeritus in the Department of Communication at the University of Dayton, Ohio. And she is also the editor, okay, of the journal Health Communication for more than 33 years. So that means actually many of us, we are in her hand. We have our papers, okay, in her hand. She's a person who has the power, okay, to decide our fate, okay. And if we try, to submit our papers, to the applied communication research, then, another, guest speaker, Mohan, okay, would, be the person in power, okay, who decide our fate. Okay, so in addition to be the editor, Professor Terry Thompson is also very productive. She has published 8 books and monographs, and then more than 70 scholarly articles. Earlier during the break, she was showing us the new book that she just she just published. Okay, so I think she will have more time to talk about that later, during her section. Okay, and Professor Thompson has been honored by the National Communication Association for her contributions to the field of health communication, and then she will deserve that. Okay, because all her life, all she have been doing, okay, is related to health communication. And also the second speaker, Professor Sandy Smith, she is University Distinguished Professor in the Department of Communication at Michigan State University. She is also the former director of the Health and Risk Communication Center there. Professor Sandy Smith, she won a lot of large-scale grants. Okay, so she has been very, very productive, and her research centers on the impact of communication on health behavior in context of breast cancer, organ donation, and alcohol and drug abuse. On top of that, she has been a very great mentor. Professor Sandy Smith has been elected as a fellow of ICA and a distinguished scholar by NCA. And the third speaker, Professor Mohan Datta, is Dean's Chair Professor of Communication at Massey University, New Zealand. And he is the director of the Center for Culture Center Approach to Research and Evaluation. He conducts so many studies, but then, if we have to summarize some of his major research area, that will include international health communication, critical culture theory, health activism in globalization politics, and public policy and social change. Professor Datta has been honored with the Outstanding Health Communication Award of the NCA and is also an ICA fellow. So you can see that, this is totally impossible, just to talk about, their, awards that they won. And then not to mention that if I have to, just, to call, the publication that they publish, I think then I will use, the whole morning. So I don't think that's feasible. But all in all, we are very, very happy that, we put together this panel, so we can learn from all 3 of them. So now that's sorry, before I start, I think I want to introduce about the structure of this panel. So this panel in total, we have about 90 minutes. I will invite each of the guest speaker to talk for about 20 minutes. And then after that, we will have the discussion section. And if the audience, if you have any questions you want to raise, perhaps you can first put in the chat box, and then I can help you to organize the questions. Okay, now let's welcome Professor Terry Thompson. She wants to talk something about reflection, her reflection of theories and ethics in health communication. Yeah. Thank you.
Hi, I don't think I signed in right because my name is not showing below my a picture. Gary says that's my prison number, my convict number. So when you see that, no, that's Terry. I am delighted to be here with you today, trying to get my slides right. It's it would be much better to be there with you in Hong Kong. I would love that. Hong Kong's one of my favorite cities in the whole world. Since we can't all be together, though, I would like to share with you a few thoughts about theory and ethics in health communication. As I looked at the initial questions that Leanne sent to the three of us, Mohan, Sandy, and me for this presentation, the issues of theory and ethics struck me because I just finished doing a book on health communication theory. So I'd like to tell you a little bit about the various theories that we cover in there and why theory is important. And then Nurit Gutman and I will be doing the entry for the upcoming International Encyclopedia of Health Communication on ethics in health comm. So I've got that on my mind too. So I'd like to share that with you. So Peter Schultz from the University of Lugano in Switzerland and I co-edited this book to give you a little bit of a perspective, since many of you are young scholars. I'd like to tell you a little bit about how it began, how it developed, and some of the travails along the way. This will be old hat to some of the more established scholars, but I hope it will be somewhat relevant to the newer scholars. So it began over dinner, as do so many good things. It was a lovely dinner. We were in Switzerland, and the Lugano district is the Italian-speaking province in Switzerland. So we were having wonderful Italian food. And somehow, can't imagine how, the topic of theory came up. And we were bemoaning the fact that not enough of our research as health communication scholars is grounded in theory. And we were talking about what we should do about that. So we started talking about we should do a book. And those of you who followed scholarship over the years that the field has been around know that much of the research in the early years was rather atheoretical. Fortunately, things have changed a lot, and now it's very rare that in the journal Health Communication we publish anything that is not theoretically grounded. So we had this idea, one thing after another got in the way until at some point, who knows how much longer, I got an email from Scott Poole, who was working on a series of theory books for Wiley Blackwell. And he said, "You think we need a health comm theory book?" To which I said, "Of course." He said, "Would you be interested in doing so?" So I said, "If Peter will do it with me." And thus the journey began. This book had more travails along the way than any book I've ever done. We just sent, as many of you know, the third edition of the Handbook of Health Communication to press by I mean yesterday or the day before. And we've had some travails with that. Nancy Grant Harrington is the brains behind that operation. So there have been some travails there. We're still waiting for one chapter, as a matter of fact. But there were more travails with this book, and this was even mostly COVID. So we can't even blame it on COVID. We had authors forget that they had agreed to do chapters for it. We had authors after the due date decide, I just can't really do this. And we had to start anew with some of the chapters. So I will be referring to that a bit as we go along. But we now have the first book in the area of study that we all affectionately call health communication theory that has come out. The book begins with a section on perspectives on the field of health communication. And the first chapter focuses on some of the basics of health communication and what it is. I'll talk more about that in a moment. The second chapter, it does not focus on theories per se, but on concepts of theoretical and operational importance. We've got Brian Quick and a number of his colleagues now spread across the country who talked about some important segmentation variables. And then, and this was again part of the travails, as the chapters were already coming in, we realized, thanks to the brilliance, as always, of Barbara Scharf, that we were not adequately presenting qualitative approaches. We had Barbara and Evelyn Ho doing a great chapter on cultural issues, but we were not adequately presenting many of the more qualitative approaches that are such an important part of our field. So, fortunately, Jill Yamasaki was on sabbatical at that time, so I was able to corral her. I probably could come up with a nicer a word, but corral her to at the last minute write a very important chapter that she called When Theory and Method Intertwine. So I'll tell you a little bit about that in a moment. So the initial discussion focuses a bit on some history and definition of the area of study that we call health communication, defining healthcare, defining what a theory is. The key part of this chapter is why theory is important. And I think this is the most important takeaway from what I would like to share with you today. As I mentioned already, we have seen, fortunately, a lot of development in health communication in terms of the role of theory. Theory is essential in I'm going to say all fields of study, although that probably is not true. I'm not really an expert on all fields of study, but it certainly is in all aspects of social science communication and health communication. Without theory, our generalizability of any research that we do is woefully limited. Theory is even more important than is sample and ecological validity for the generalizability of our research, in my humble opinion. If I am able to generalize the findings from a study on diabetes to a study on HIV or COVID because of shared theoretical frameworks, the field is able to build much more adequately. And then, so that's an important point for us to keep in mind, I think. We go on and talk about some of the traditions of theory in the Bob Craig sense, some of the generative tensions underlying health communication research, as Austin Babrow and Mary Fran Matson talked about it in the first couple of editions of the Handbook of Health Communication. Then we do some previewing of what we'll follow and talk about ethics, which is the topic with which I will end my discussion tonight. As we were putting the book together, we realized that there were several important concepts that were not really theories, but that had theoretical import and that were particularly relevant for segmentation. So we asked Brian Quick, Mike Mackard, and several of their colleagues to write a chapter that covered these key variables. The concepts on which they focused were involvement with the topic, with the message, with the audience, health literacy, locus of control, reactance proneness, and the notion of reactance also comes up in another chapter, issues of self-monitoring and sensation seeking. As I share these ideas with you, I'm hoping that you will think about how you can incorporate um, the theoretical notions in the work that you do. Theory should be the starting point for our research. So then the third chapter, authored by Jill Yamasaki, begins with a quote I'd like to share with you directly. Given the nature of interpretive critical approaches to health communication research, it is not always possible, practical, or desirable to consider theory as distinct from methodology and representation. That's why the title, Theory and Method as Intertwined. So that's different than is the case for the more post-positivistic perspectives that are clearly theoretically based in a lot of other areas of the field. Jill focused on, what do we have here? Five important concepts, like you don't know what five is unless I show you my fingers. Huh? She just starts with the discussion of philosophical grounding of the whole area of interpretive and critical approaches, moves on to grounded theory, talking about theory as process or product, then narrative theorizing. And this is one of only of two or three places where narratives are discussed in the book. The important concept, method of autoethnography, and then the rhetoric of health and medicine, so a rhetorical perspective. The next section focuses on some interpersonal dimensions, dyads, and groups. The first chapter within this section is just simply called Interpersonal Communication and Health Theories. Now, this is the one that we had to replace at the last moment. The author who was originally planning to write this asked a co-editor, like a co-author, and things didn't work out. So as the book was close to, we had hoped, being ready to go to press, we had to try to cover some very important interpersonal health comm theories. And we ended up asking three groups of researchers to write these different sections. No one was felt expert enough on any of them by themselves to take them on. So it's set up in an unusual way. Talk more about that in a moment. The second chapter in this section is a wonderful one focusing on families interacting in the healthcare context. Maureen Keeley and Hannah Jones. Hannah is a doctoral student at Rutgers, although I believe she was just in between her master's and her doctorate at the time they wrote that, which should help inspire some of you young scholars. And then an all-important chapter on theoretical frameworks of provider-patient interaction by Peter Schultz and Xiao Hai. So the interpersonal health chapter ended up with three primary foci: communication accommodation theory, which has been used a fair amount in health communication to look at how we adapt our communication. Many of you will think back to, of course, Howie Giles and Rick Street's early work on this topic. So this a section presents a very important way to incorporate an accommodation perspective into interpersonal health comm work. Then we move on to communication privacy management theory developed by Sandra Petronio, who fortunately is one of the authors with a couple of other colleagues from IUPUI of this important perspective. As many of you know, we use this a lot in health communication, although it is not uniquely applicable to health communication, but applicable to all interpersonal contexts. And then Maureen, after already having written, Maureen Keeley, after already having written the family chapter, was willing to take on for us the theory of negotiated morality. So we have a wonderful section on that. And now, while I'm casting this in terms of sharing with you what the book is about, I'm hoping that you're thinking about it in terms of how can I take these theories and incorporate them in my research. In the family chapter, we talk about four important theories: the double ABCX model of family stress and coping, Olson's circumplex model of marital and family systems, inconsistent nurturing as control, builds on many of the notions that originally started with Bateson's work on double binds, and then affection exchange theory, building most directly on Corey Floyd's work, although extending beyond that now. It has so many applications beyond health, but has really important applications to health communication. And then Peter and Shahai tie this section up with us with a section that Peter called proto theory in studies of provider patient communication. Provider patient communication, in many ways, is one of the more difficult to frame theoretically. Much of the research on provider patient interaction has not historically been theoretically framed. So Peter and shall I share with us some of the kind of proto theory concepts and studies that can help us make sense of this. Moving on then to the ideal of patient-centered communication. I'm hoping that most of you are already familiar with the importance of this concept, patient-centered communication. The most important part of this chapter, I think, is the portion that focuses on the pathways linking communication to health outcomes and improvement. The heritage of antiquity takes a look at some of the more traditional, antique, I guess we should say, perspectives that can be applied to doctor patient or provider patient communication can be and have been. Narrative medicine, health and rhetoric, and argumentation theory. This one's an interesting one because it's one we frequently don't think about, but the whole process of provider patient interaction is one of argumentation. So, some really interesting insights coming out of this. Then, several relational models going back to one of Gary's, one of the earliest in the field's relation communication competency model, and including a discussion of dialectical tensions, which has been used quite a bit in health communication, and concluding with a section on some theories related to social and public conduct, politeness theory, stigma mass management, communication theory, some perspectives that are more relevant to social and public contexts. Various perspectives on influence processes are discussed in the next portion of the book. We know that so much of communication, and particularly, I would say, health communication, are influence processes. So we have Monique Michelle, Mitchell Turner, and two of her colleagues sharing with us information processing and cognitive theories. Robin Naby talking about theories of affective impact. Marco Weiser and Rebecca Naylor discussing theories of behavior, and then Danny Robinson, Yan Tian, and Michelle Turner talking about theories of message effects. The information processing and cognitive theories chapters begins with the notion, quote, I'm not recalling who said it, but Monique and I'll tell you, we are addicted to our thoughts. And so they talk about the multiple motive heuristic systemic model, attribution theory, the health belief model, and then 3 risk perspectives. Theories of affective impact focus on reactance and dissonance, psychological discomfort, some fear based theories of influence. We know that's been important in the field, oh gosh, since Hovland et al. And then some general theories of emotional influence. And within this chapter, Robin makes some new theoretical contributions. So that's something useful for you to look at. Theories of behavior focus on 3 important ones: social cognitive theory, reasoned action theory, and of course, tying in the theory of planned behavior, and then the trans theoretical model of behavior change. We got a whole bunch of theories about message effects because they're all relevant to health communication. Agenda setting, cultivation theory, narrative engagement framework. I told you narratives would come up again. Framing theory, inoculation theory, uses and graphs, and then media complementarity theory. I think, Mohan, you developed that, didn't you? The next section focuses on organizations and society. We've got some social psychological theories discussed. By Tony Roberto and one of his colleagues, theories of public relations introduced by Arunima Krishna, theories of uncertainty. We know how important that is in health communication. So the wonderful chapter that I already mentioned on cultural theories of health communication. And then this section closes with a fabulous chapter on digital media technology. The 4 social psychological theories are diffusion of innovation, social judgment theory, self-determination theory, which from many of us know, was originally an Orcam theory, and then social comparison theory. The three theories that are discussed relating to public relations are situational theory of publics, situational theory of problem solving, and communicative action in problem solving, all of which take this area of public relations, which was initially very atheoretical, and talk about how we need to adapt to different audiences. The theories of uncertainty examine harm reduction, something we don't talk enough about, uncertainty management theory, theory of motivated information management, and problematic integration theory. Cultural theories. This is an immense chapter in terms of the focus of the content. So I'm just going to give you a little picture of it. They start with some of the interdisciplinary foundations of this view, and then look at culture as variable, as context, and culture as critique. I think Mohan will tell us a bit more about that. And then the digital chapter has two basic foci, the cue route and the action route, with a number of theories within that. Finally, the book concludes with a fabulous chapter by Danielle Keeley and Brian Sothwell on perspectives on the future. They talk about several needs for multi-level system-oriented thinking, longitudinal theorizing, translational implementation and dissemination, integration with regulatory science, and then the need to theorize about misinformation. We study it, but we don't theorize about it much. Wouldn't that be fun to do? I will look forward to that. Last thing I would like to leave in your consciousness is the always important impact of ethics in any a line of research, but for us, for health communication. So we need to focus on ethical concepts in terms of the guiding precepts, the ethical issues that are especially relevant to clinical and organizational contexts, those particularly relevant newly for many of us in digital and social media. And then, and I think this is where in health communication, we first studied ethics in campaigns, in the health communication and social marketing campaigns. So I will return to our discussion later with any questions that you have, but I will shut up now.
Thanks to Terry's talk, now she just proved that she is the living dictionary of health communication. And also after today, no students or scholars can complain that I cannot find any, health communication theory.
Good.
Okay,
Good.
so thanks to Terry's very comprehensive and then very informative, talk. And then we will come back to the discussion later. But now let's welcome Professor Sandy Smith. And then her talk will be something related to the transdisciplinary health research and implementation. Oh, by the way, Professor Terry Thompson, usually her voice is not this sexy. She informed us that she got a bug, and then therefore, actually, I believe that, she must have like a sore throat, but then yet, she still tried, to deliver this talk. So thank you very much, Professor Terry Thompson. And now let's welcome Professor Sandy Smith. Thank you.
All right, thank you so much. I'm trying to get this to start in the right way, but it's not behaving for me. Oh, I think I see where it is right here. But the wrong slides. There we go. It always takes me a little while when I'm teaching classes. First of all, I just want to thank you so much. It's such an honor to be invited to give this presentation tonight, and especially for Terry and I to come back virtually this time, though, to Hong Kong Baptist University. We were so impressed both of us when we were there, and we were fortunate enough to be there with Chuck Atkin, my late husband at the time. So we can't remember exactly the year, but it was a magnificent trip, and it would be wonderful if we could all be there together. Today, I wanted to talk about a very different type of research maybe than you've heard about before. I didn't know about it until a little later in my career. So I wanted to introduce it to you in case it's something that would appeal to you. And that is that as communication scholars, I've found that we really have a place at the table in transdisciplinary health research and implementation. And I want to talk to you from a couple of different perspectives about this. The first thing that I want to do is just define transdisciplinary research, but I want to say Gary, I believe, is on the call, that Gary and Ed Maybach introduced this concept to us in 2008 in Journal of Communication, where they talked about a transdisciplinary merging between public health and health communication to public health communication. I'm going to talk about some disparate areas that can come together today. But this is basically research that's conducted by investigators from different disciplines, and they're working jointly to create new, and I'm going to go through each of these in order today, new conceptual, theoretical, methodological, and translational innovations that integrate and move beyond discipline-specific approaches to address a common problem. And I'm so thankful to some of the earlier presenters, because I believe you set me up well for this. But the idea here is this is beyond interdisciplinary. So as I try and explain it to you, excuse me, as I try and explain it to you, just imagine now we're moving beyond interdisciplinary and we're trying to form a synergistic new way of thinking about things by virtue of us interacting with one another. So in order to do this, excuse me, my throat was closing up a little bit. We need to have a problem or an issue that's really too vast for one field to address. We've talked about some of these earlier with dis and misinformation and some of the other things that are very important to us right now. And what we want to do is to get together a group of researchers from different relevant fields that come together to work on solving or mitigating this problem or issue. I'm going to talk to you about one of them in just a second. So each group of researchers from your particular field, so if we were communication scholars coming, we're going to bring to bear our expertise, but we're going to try and merge it with the others to form a true transdisciplinary team. This obviously has to occur over a long period of time. So the one project I'm going to tell you about started in 2003 and just somewhat is winding down as of now or last year. So that's quite a long time, you know, that's 17 years. Another one that I've been working on has been for about 7 years. But I want to tell you that communication scholars really have a lot to bring to this table for health-related large-scale research projects. I'm going to try and show you how that might be for you. The first thing I want to do is tell you a little bit about this breast cancer and the environment research centers, which morphed into a research program, and that's the one that started in 2003. Oddly enough, we don't have enough time to tell you the whole story, but the Department of Defense was the first group to really back breast cancer research in terms of environmental factors that play into it, and got the National Institutes of Health, in particular the National Cancer Institute and the National Institute of Environmental Health Sciences in the US involved in it. And the idea behind all this is that they're chemical, so some of the very slides that Jeff had up feed into this. They're chemical, they're physical, and they're social factors in the environment, but they interact with genetic factors. And these can affect mammary gland development during puberty, but also across the lifespan in ways that can alter our risk for breast cancer later in life. So this project has researchers from biology, epidemiology, communication, but also, very importantly, community advocates were on our transdisciplinary team for the whole time that we worked together. There were some challenges to this, which I'll tell you about later. So I wanted to go through the conceptual, the theoretical, methodological, and translational for you in terms of this one project. This is conceptual, very loosely defined and applied, but we were able to document beliefs and attitudes and behaviors of relevant stakeholders. And as I told you in the last slide, these would be prepubertal and pubertal girls and their caregivers. And we were able to do this through formative analysis. And at the same time we were working on that, the epidemiologists were working on getting cohorts of girls and testing them throughout time. And the biologists were working on rat and mouse studies. And what we were trying to do was all come together. And so the biologists were working most closely with us. And so they came up with some important findings. And we designed, we refined, and we tested the messages that came out from them. And we looked at message processing, that people could understand health literacy, all different sorts of things there. And then we did not create the communication campaigns, but a private company did. So they were created, but they were disseminated and evaluated. We evaluated those communication campaigns. And we did that based on all the previous evaluation work. And then finally, this last section of what we did was to teach communication skills to stakeholders. So we have extension agents in certain schools in the United States. I know Cornell happens to be a land-grant school as well. And these are people who go out throughout the state and spread information. A lot of times it's about agricultural issues, but they definitely were out trying to help us. And we were teaching them both how to spread information, but also how to conduct focus groups themselves. And so we taught them a lot of important skills. And then finally, we created a 3-hour continuing medical education program with our public TV station here on campus. And so that has gone out to pediatric healthcare workers and it's all been evaluated. So you can see here how over the course of these 17 or 18 years, all these different things have come into play conceptually. I'm going to just quickly go over the theoretical and methodological with you, but just some of the theories that we used. And of course, Terry just named so many important ones, but we used the health belief model, uncertainty management theory, the heuristic systematic model, diffusion of innovation, as we were carrying out all the work that I just talked to you about. And we used different methods to gather our data. We used one-on-one interviews. We used focus groups. Surveys came into play at several different points during this long project. We used 1 or 2 experiments and then definitely content analyses because we wanted to see the kind of information that was coming out in journalistic outlets about breast cancer and the environment in particular. And then the translational efforts, I think we are also well suited for this in health communication. Of course, we publish our results in academic journals, but at the same time, when you're working on this transdisciplinary team, or probably in a lot of the research that we do, really the onus is on us to translate the findings so that they're going to the public and to people who can really use our scientific findings that have been discerned. So that is a very novel thing for a lot of researchers, in particular our biologists. We're not used to this at all. So including communication scientists to lead the translational efforts was really helpful because we want to develop and disseminate theoretically informed evidence-based content. And we were able to do that on this project. I'm really proud of it. All right, so I wanted to imagine if I was in your place and was young again, how would I go about, oh, this sounds really appealing, Sandy, but how would I go about finding something like this? So I remembered an email that I just got recently from our National Science Foundation in the US. And it was talking about these transformative projects that they wanted to start funding. So they identified these 10 transformative big topics, and they said they're going to require novel approaches and methods. And they actually came out in the call and said it's going to involve collaborations with people from multiple disciplines, of course, the transdisciplinary, but people from industry, people from private foundations, other agencies besides NSF, science academies and societies and universities. And one of the things I think they probably left out that I wish they'd come up with would be advocates who are lay advocates in particular. So one of these large scale transformative projects is called, this is how big it is, Understanding the Rules of Life. Well, that's pretty, grand scale, and predicting phenotype. But within that umbrella, different directorates are coming up with different calls. And there happens to be a directorate called Social, Behavioral, and Economic Sciences, which is very relevant, I think, to everything that we do. And their call is Understanding the Rules of Life, Emergent Networks. And they actually talk about a focus on intertwined networks from the cellular to the individual to the group, the organizational and societal levels. But certainly all the network analysis work that people in our field do would be quite relevant here. So I'm just saying that this is one example of a place that you could go to look to try and form a team, or if you knew of somebody who was working on it, to offer the services of communication scientists. So what health and risk issues lend themselves to transdisciplinary research globally and in Asia, from what I understand? And Terry just talked about patient-centered research, and for 5 years, I've served on the Patient-Centered Outcomes Research Institute for one of the panels that is there on communication and dissemination. And one of the wonderful things that they do, they have quite a bit of money, quite a bit of grant money that comes from insurance companies in the United States, including Medicare. And they make every single group who applies for one of their grants have patient advocates involved right from the very beginning of the whole idea behind the grant and all the way through. So that it's important that we're getting to the level of patient-centered health, I think, and that's certainly something that could be transdisciplinary. Health across the lifespan. I was looking at some websites of some research institutes there in Hong Kong and across Asia, and I saw different focuses, different foci on infants, on children, adults, the aging. As I talked to you about in the breast cancer work we did the prepubertal and pubertal girls, although males can get breast cancer too. Another huge issue is e-health, and of course tying into the next one of dis and misinformation that we heard so much about in the last panel that was really interesting and informative. And then I understand right now, sort of in that realm, there's a transdisciplinary team studying the origins and consequences of infodemics during COVID-19 in 4 societies there: mainland China, Taiwan, Hong Kong, and Singapore. So there's certainly research out that lends itself, research topics that lend themselves to transdisciplinary research for you to try and find and locate. And I asked myself, well, how can we prepare ourselves to have a seat at this table for transdisciplinary research, health research as communication scholars? And I realized, well, we already do it. So I think we just need to bring to bear our knowledge of health communication theory and methods, our knowledge of communication campaign processes, our knowledge in being able to train experts in other fields and various, aspects of communication. And then I just wanted to note to you that the other transdisciplinary team I've worked on has people from criminal justice and psychology. And in particular, the people in criminal justice just were so fascinated by our focus on messages, because it's just very unique in the world of research. And it was so fruitful. We looked at memorable messages and at social support messages in the criminal justice arena. And they just loved that instead of looking at, societal level. So I know there was a call earlier to look at these other levels, but I just want to tell you that don't lose our focus on messages, because it's really unique and important. So what are the benefits and barriers of that kind of research for communication scholars? Well, a definite benefit is exposure to other disciplines when we have a common focus that we're all looking at, and you can understand how other people approach it. Certainly excitement and pride in the work of the team. And I think as we hit some benchmarks and we got excited, and it brought us together more as a team. Very long-term projects, as I've told you, which is great for your career, I think. Usually they're really well funded. That was talked about as an issue earlier too. However, there are a couple of drawbacks. I wouldn't try and get on a transdisciplinary team for a quick turnaround of something, because it just takes a lot of time to create our ideas and projects and to work as a team. And we found, at least we felt, that we had some difficulty in gaining respect. I believe that somebody earlier was talking about that on their own campus as well too. Sometimes people don't understand what communication scholars do. So that took us years actually, but we finally cracked the barrier and gained the respect of the other people. And then we also have problems agreeing on issues such as when it's appropriate to publish findings, because the biologists did not want to publish the findings at the time that the advocates wanted to publish them and disseminate them. So these were just some of the things that were both very nice benefits and some drawbacks as well. I want to move to something that we were asked to do, and that was to give some advice for Asian health communication scholars, for younger scholars. And so I went to a few of my colleagues and students who are Asian scholars in the US, but I have to give you a fair warning. And that is, for those of you who don't know about Michigan State, we really operate in the post-positivist perspective. So everything that I'm going to tell you might not be good advice for interpretive or critical and cultural scholars. And I'm sure Mohan will help me with that when he talks. But some of the advice they gave was to develop networks across fields and locales, because that can be a bridge for you to other parts of the world. So as we go, say, to ICA, to try and develop those networks if you can. One of them suggested going beyond replications or retest of Western theories. I'll tell you in the next point how I think you could take that, because it could sound kind of horrible, or to move beyond a niche study of a local phenomenon. And I believe what this person meant was to decontextualize your research. So I think it's fine to do the retests and the replications. Well, of course, replication is an important part of science, but at the same time, maybe decontextualize the research to focus more on the theoretical advancements that you are making and let the world know about that. And also the advancements that you're making to the communication phenomena under study. So you could talk about a local phenomenon, but then show how it could be generalized to other areas as well. They suggested that you translate academic research findings to places where real life impact is possible. I completely agree with that as well. To use shared academic language, to build or find common ground with other researchers, and to make analogies in social problems and solutions. Disseminate your research widely. And then this was also mentioned in the first session, to do all of this while remaining mindful of what your academic institution values and rewards. Never, lose sight of that. So that is my advice for you, which really comes from other people. But I do want you to know that I'd be more than happy to talk to any of you. If you have any questions that go beyond this evening, you can get a hold of me at my email address right there. And I'm generally really good at answering it. So thank you so much. And I will try and figure out how to stop my share here.
Thank you
I
to
did it.
Professor Sandy Smith. Okay, thanks for the very generous experience sharing. And also, I learned that usually Sandy will go to bed early, so now it's quite like she is having her jet lag now. So thanks for staying late with us. Okay, so then we'll come back to the discussion later. But then let's welcome our third speaker, Professor Mohan Datta. When you are ready, please.
Thank you so much for having me in this conversation, Leanne, and it's really a pleasure to join you all. It also is an honor to follow Sandy and Terry, both of whom I have looked up at as mentors. What I will do today is sort of build on the points that Sandy and Terry have raised about translational research, key aspects of transdisciplinarity and key theories of health communication, and talk about it within the context of what does it mean to build Asian imaginaries as the basis for theorizing health and communication. And I have put in there transformations in as the basis for thinking through this, because I'm really interested in the question of habitus, meaning that how do we take our location and our specificity in Asia seriously, and ask the question, what does it mean to theorize from Asia, to theorize in Asia, and to theorize about contexts and empirical observations that are emergent from within Asia. As I do this, I will draw upon my experience as head of a department of communications and new media at National University of Singapore, trying to forge a program that took this question of Asia seriously and trying to build health communication conversations out of that position at NUS, and really thinking through what does it mean to nurture Asian theories. As I do this, I will, of course, also draw on the work of CARE, the Center for Culture-Centered Approach to Research and Evaluation that was founded in Singapore and that works across 13 countries in Asia, and then offer some insights in my role as the editor of the NCA journal, the Journal of Applied Communication Research. So the way I will position my talk is to begin by discussing what I see as hegemonic health communication theory and the trappings of health communication theorizing within Asia, within these broader structures of hegemonic health communication theories. I will articulate how I see these as colonizing structures situated within metrics games of Asian universities, which actually prevent us from theorizing in ways that are meaningful to Asian contexts. So within that sense, I will discuss institutional barriers and the ways in which I see metrics themselves as colonizing processes that prevent serious theorizing. And then from there, then I will talk about Asian imaginaries and really thinking through how do we decolonize these hegemonic conversations. So I want to begin by asking this question because, Leanne asked us to talk about theory in health communication. And I thought, that's an exciting challenge, particularly in terms of thinking through this question of who defines theory. If you historically look at the landscape of theorizing, and I have sort of painted this picture, this map of the globe into the blue and the red. The blue is what's considered global north in theorizing of the north, and the red is the global south. The first thing to note is that in terms of the distribution of population, a majority of people across the globe reside in the global south, which is the red. Also, of those inhabitants of the global south, a large portion of them reside in Asia. Much of the theorizing, however, in fact, over 90% of the theorizing in communication, and certainly theorizing in health communication, happens in the global north. So you can see where I'm going with this, that in terms of the specter of theory and theorizing, we see a fundamental inequality in terms of who does the theorizing and who gets theorized upon and what bodies get theorized on. And in articulating this inequality, then I will draw upon two recent pieces. This is a piece in communication theory with a special issue I edited with Dr. Mahua Pal at University of South Florida, which is theorizing from the global south, dismantling, resisting, and transforming communication theory. And in this particular special issue, we were interested in this project of building theories from the global south with a particular mandate on inviting scholars from spaces in the global south to do the work of theorizing from Asia, from Latin America, from Africa, those spaces in red that you saw earlier. In this particular piece, then, we argued that the specter of communication theorizing with its COMSO-white formations is constituted such that the work of theorizing takes place amidst whiteness and amidst really predominantly structures within the US, and of course with extensions of it into Europe, but that still retains the whiteness of theorizing. What then within that context does it mean to foster and create spaces of theorizing from sites of the global south? And in that we argue that it is fundamental to rework infrastructures, rework institutions, universities, organizations, so that they enable this kind of theorizing from our habitats in the south. Certainly, we felt in this particular piece when we reviewed the literature that even as we see extensions of internationalization or de-Westernization that extend into Asia, for instance, that is often a replication of Western, predominantly white theories, so that the nature of theory building work becomes one of testing theories that have been constituted within the logics of the North without really interrogating the fundamental principles and logics that constitute these theories. In another piece that's published in Communication and Critical Cultural Studies, edited by Tom Nakayama in a special issue on whiteness and communication, and I titled this Whiteness, Internationalization and Erasure, Decolonizing Futures from the Global South, I argued that much of the current conversation on decolonization simply takes white US-centric frameworks and reproduces them without really asking to what extent do they fit within the contexts, but moreover, continuing the colonizing processes so that the fundamental inequities in theorizing continue to be reproduced. So how does this then connect to health communication? In hegemonic health communication, and here I build on the pioneering work of Collins Archihenbua, who made some of these fundamental points, which is, Archihenbua argued that if you look at hegemonic health communication theories, they foreground the individual, they foreground cognitivism, that is, they work on the principles of thinking and thought and cognition that drives human enactments and relationships and constitutions within ecosystems. They take a rational actor model embedded within logics of rationalism and linear rationalism at that. And that then gets played out in the overarching framework of message centrism. So the dominant understandings in this framework is that you take the message, you design the right kind of message to persuade the individual to produce the right kinds of behaviors. So extending Archihenbua's work, then I have argued that this particular logic is an embodiment of whiteness, because It depicts the fundamental assumptions of white cultural values in terms of what human beings are and how human beings work. And within that, then US-centric white cultural values tied in with logics of capital without interrogating notions of relationality, without foregrounding notions of community, relationships with Earth and the ecosystems, and considering the broader structural contexts within which people inhabit their lives. This then has to be situated in the backdrop of the capitalist onslaught on Asia, and particularly the neoliberal onslaught on Asia since the 1980s, and then that has accelerated since the 1990s, which has meant that this kind of individualization that you see in health communication theorizing is replicated in the capitalist onslaught that has foregrounded logics of profit extraction, labor exploitation, fundamental systems of capitalist expansion that threaten human health and livelihood at their very core. And this is what you see in the works of Arundhati Roy when she says that the pandemic is a portal, talking about COVID-19, is that so much of Asian ways of imagining have been so fundamentally co-opted within the logics of capital that the only pathway monolithically that we see for us are the capitalist pathways to progress and development, simultaneously obfuscating key aspects such as exploitation of ecosystems, destruction of these ecosystems across Asia. You see, for instance, ongoing destruction of forest systems, ongoing destruction of sand and acquisition of land in the name of development. And this is constituted in the backdrop of precarization of work. So as people are displaced from the spaces of their life and livelihood, they are constituted within, thrown into these logics of migration without opportunities to organize as laborers, without opportunities to collectivize into unions, without fundamental labor rights. And that constitutes the basic threats to health. Privatization of public resources, of community and communal resources, and really in the backdrop of all of this, destruction of communities under the logic of individualism and the individualized pursuit of the market and freedom as the market. So within this kind of theorizing, then you see how capital replicates, the logics of expansion of capital replicates the architecture of US-centric health communication theory embodied in whiteness. The Asian university becomes a site of replica of whiteness. And I thought that I will take this image from popular culture to articulate what I mean here. And this is an advertisement in Singapore. And for those of you that are familiar with Singapore, you will see preponderance of ads such as this that sort of articulate, in fact, this desire for whiteness. So this particular desire for whiteness pretty much plays out in Asian universities and in their chasing of metrics, in their articulation of what is knowledge. So in that process, they set up these colonizing structures that replicate whiteness. So logics of whiteness are adapted into Asian contexts as replicas, where we are promoted, we are rewarded for reproducing and circulating the constructs that are embedded in whiteness, and often circulating the racist ideology of whiteness. At the same time, devaluing cultural contexts and articulations that are tied to people's ways of living and their everyday struggles. Culture is often put in as an afterthought then, or as a variable that circulates these hegemonic essentialisms, such as individualism, collectivism, that is often thrown in as a construct, while at the same time erasing the richness of contexts. Culture as cultural sensitivity becomes a way for reproducing the hegemonic logics as if adjusting to culture as a variable, while at the same time undermining the communal, the connected relational ways of being. So this entire structure then is facilitated by metric regimes that reify the hegemony of whiteness, having mentored Asian scholars, having really struggled with trying to create infrastructures for doing Asian health communication scholarship. I think the thing that stands out to me is the ways in which the whiteness of the metric game prevents any serious Asian theorizing from taking place. So that scholars in major institutions in Asia are rewarded for publishing in US-centric journals, which continue to retain, reward, and circulate the US-centric logics. And I look at my own journal when I think through that, all the way from the fundamental logics of what it takes to get published in that journal to what even is considered as theory, going back to my initial point about theory. So these metric gains in that way actually reproduce and reify those systems such that at the end of the process, what you end up getting, even as we internationalize, and that was the argument I was making in that piece on internationalization, is a reworking and reproduction of US hegemony of theorizing. So how do I then, in this backdrop, think about the challenges of health in Asia? And the first argument I make is that the ongoing challenges of health in Asia, the midst of these onslaught of capital and neoliberal extremism in some ways, is the necessity to foreground structures. And certainly COVID made this visible in so many powerful ways. This is an image I have of many Asian development. Many pictures of Asian urbanization are somewhat like this. So they are made to look good and beautiful and sophisticated to the Western eye, while what actually underlies that, and there is a huge underbelly of deprivation, of dispossession, where actually will find dramatic health inequalities. So within this context, the culture-centered approaches of meta theory talks about how we need to look at culture as constitutive of context to foreground the agentic capacity of communities, of peoples, to articulate solutions that fundamentally challenge the structures that threaten human health and well-being. So in the work of CARE, and I wanted to use that as the basis to talk about what then this possibility of theorizing from Asia looks like. And CARE now works in about 13 countries across Asia, and we train community researchers, activists, working in multiple communities, designing all the way from community-led interventions, addressing issues like chronic disease or infectious disease, to designing infrastructures such as community-led hospitals or healthcare infrastructures, to activist interventions, because the kinds of inequalities I was talking about call for activist interventions to transform and challenge the structures, to policy-based frameworks to converse with policymakers and advocate for policies, to actual movements, labor rights, transgender rights, sex worker rights, anti-racist interventions, struggles for land rights, all of which I see as fundamental struggles for ensuring health and well-being. And you see, this is the hegemonic US centrism and whiteness of the literature, which will, of how we have approached health communication historically, is that it will often ask, what does this have to do with health? While fundamentally, these questions about rights, about the environment, about land, about food, are what are at the heart of the struggles for health in Asia. So disease and Asian imaginaries, I suppose I see them as registers for thinking about the exploitative conditions within which large parts of Asians struggle, the hyper precarity of lives, the lack of adequate wage and income, the poor living and housing conditions. We certainly saw that in Singapore amidst COVID-19, which became the site for the outbreak of COVID-19, the extreme inequalities in Asia, the massive food insecurities that we witness in Asia, barriers to accessing testing, accessing healthcare, and the ongoing cycles of poverty. So I see the work of theorizing health communication as the work of transforming structures so that we can create equality in the distribution of fundamental structural resources, all the way from income and wealth to opportunities of life, information, evidence, knowledge, which is tied to the project of building communicative equality in terms of ownership of information resources, resources for making knowledge claims and creating evidence, resources for building representation, decision-making, and voice. So this is all structured within the struggles for building infrastructures of listening so that communities that we work with, whose health we seek to work with to improve, actually have registers for their voices to be heard in ways that are meaningful so that their health and well-being can be improved. And so that we can actually sustain these efforts of health and well-being by communication infrastructures where communities can build networks of solidarity in their struggles for better health and well-being, where they can have communicative sovereignty, where they can actually own or feel sense of ownership of those communicative infrastructures on which they can articulate their voices, where they can connect across spaces and build multiple nodes for articulating their voices. And finally, what does it mean for us to actually do health communication work to improve people's health, if that is what we are committed to, by committing to these processes of change? What does it look like when health communication is directed at addressing these fundamentally unequal structures? What does it look like when you want to do health communication as challenging the extractive modes of capitalism? What does health communication look like in building socialist infrastructures for health and universal access? Americans today are struggling, and COVID makes this visible in the US. Americans today are struggling with the privatized healthcare system that has fundamentally been depleted by logics of capital and individualism. Let's not put that as a model that we aspire to. Let's look at that as a model that fundamentally needs transformation. And maybe there are things there to learn from many Asian ways of organizing health and healthcare systems. So with that, then how do we regain back Asian articulations of health as a human right, health as a socialist resource? So the struggle for communicative equality, I see in this sense, as also a struggle for socialist politics. And socialist politics meaning health as a fundamental human right that is connected to equal distribution of health resources, preventive resources, distribution of income, education, food, and shelter. So this is my last slide. Asian imaginaries for theorizing for me are about imaginaries for anti-colonial futures. And I go back to the anti-colonial struggles of the 1950s that shaped many Asian imaginations within the context of newly emerging post-colonial states. So we need to think about how do we build Southern capacities to imagine, Asia as Southern spaces to imagine based on ideas of sovereignty, relational ties, familial frames, community, communal good, and public good. How do we build Southern theory by facilitating South-South knowledge flows? How do we dismantle the logics of neoliberal capital and the underlying hegemony of India? How do we build generative futures that are anti-capitalist? And I thought I will put together this image from a community food garden that emerged as an example of community-driven health, where the community defines health as fundamentally sovereignty over food, where community owns its access to healthy food. And that, I hope, offers us some ways of thinking through how we can fundamentally think of Asian health communication as an anti-colonial way of looking at health communication. Thank you.
Thank you very much, Mohan. I appreciate your talk, as always, because you can always help us to diversify, the ways of thinking about health communication. So before we open the floor for questions, I'm going to use my privilege to ask the three speakers. I prepared 2 questions for them, and then I hope that I can ask each of them to share with us about their reflections on that. The first one is about theory, and then the second one is more elaboration on the suggestions for the younger, for the young scholars. So my first question to all 3, speakers is that, all of you are, either, in a position, currently in the position of, the editor, or, you are, experienced grant applicants, or, anyway, you are, very, experienced researchers. So you must have been, involved in, various types of, transdisciplinary research, or yourself, you observe other people's, transdisciplinary, research, right? So then, my question to you is that, can you, I know that you all talk about theory before, but I just want to know more about how you can, position the importance of theory in those transdisciplinary research, because sometimes we observe is that people from, for example, from public health or people from other disciplines, they may have different perceptions about the importance of theory. So then if you are in the, in a team, how can you, try to persuade them that, oh, okay, so we are going to use, this, theory grounded or theory, based, approach. And of course, I know all three of you are talking about theory from different perspectives, but then, can you, just share with us more about, your, idea about, the role of theory in those kind of, transdisciplinary collaborations? Thank you.
Sandy, I think you should start this.
I'm happy to start it. Thank you. Well, your question actually was very enlightening to me, because I realized that maybe those words I said about being transdisciplinary and synergistic might have not been completely accurate in some of the work I've done, because I think the communication scholars I've worked with have been relied upon to deal with the theories that dealt with the communication aspects of our projects. And so we weren't completely synergistic in that. But I will say that probably the one theory that I think resonated the most for everyone, and that they were probably familiar with before, was diffusion of innovation, started by Eve Rogers, actually having to do with agriculture. But of course, it has so many different applications. So I don't know if that's enough of an answer, but I want to give time to Terry and to Mohan.
Mohan, you go next. My voice isn't doing very well.
I think it's a great question, and I agree with Sandy. I think the challenge there is even articulating what health communication brings to that the conversation. And I suppose, for me, the point is working in a transdisciplinary context, and I work with architects or with agricultural engineers. And I think the challenge there is to begin with what really is the problem, and then starting from the problem to think about what does communication bring into it, and almost always there is a communicative dimension of the problem that needs exploring and digging into. So for me, it is, a dialogic spirit and an openness to having that dialogue and to really understanding as much from others about how they see the problem as it is about bringing our own understandings to those conversations.
Is everybody
Terry,
looking
will you
at
be
me?
able to talk?
Hey, let me save my voice for questions for which I have more insight to add, because I'm not thinking of anything brilliant to add to what Sandy and Mohan just said.
Oh, then, sorry, before we open the floor, I have the second question. Is about, your suggestions for the younger generation. I know that, Sandy already covered that. So, but then for Mohan, okay, and Terry, if possible, if not, you can you can pass, because I can feel that, now you really feel a little bit painful. But then Mohan, do you want to give us, just briefly, share that, okay, any suggestions that, you will give to younger, scholars, especially in this region when they conduct health communication research? And Sandy, please feel free, to, add more comments. Yeah.
Maybe, are you sure it's difficult for you to go, is it? I mean, I would love for you to go in front of me if you want to.
Oh, well, I can share a little bit about this. I think one of the things that really was inherent in what both of you had to say earlier was the notion of reaching out in a networking sense, and that's such a Western word, but so important for, I think, young Asian scholars. One of the things that I've been struck by with particularly the young scholars from China, with whom I've had contact, is the relative lack of mentoring that they get from the senior scholars compared to what I would expect. I've had a number of young Asian scholars reach out to me because they're not getting much mentoring from the more established scholars. So I would encourage that to reach out across networks and across disciplines and fields and areas of a study, and to try to overcome the lack of mentoring that a number of young Asian scholars seem to experience.
I love this idea of reaching out that you articulated, Terry, and I just want to build on that a couple of thoughts. The first thing I want to say is believe in yourself, and believing in yourself for me is believing in your context and having enough faith to know that the context that you come from has things to offer to teach you. You don't have to keep replicating in order to actually build theory and find a way for yourself to survive in the academe. That's the first thing I would say. Second thing along those lines then is be a social scientist. As health communication scholars, if you are social scientists, be a social scientist. Don't be ideologically committed. And what I mean by ideologically committed is don't bring the blinders of theory and then ask the question, how do I replicate it to addressing this problem? But really attend empirically to what you see within that context. Let the empiricism emerge and guide you in doing and developing your theory work.
That, excuse me, if one looks at Mohan's career and the movement of his research over time, you see a perfect example of doing that. And I think Gary has something to add here.
Yes, thank you. I wanted to mention that I've been working in China quite a bit for the last decade. And I've been working with Professor Guoming Yu, who is at Renmin University and now at Beijing Normal. And I found him to be an incredibly strong mentor for his graduate students and postdocs. But it's a very different form of mentoring than we do in the West. It's a much more like tough love kind of mentoring, where he basically puts them in positions of authority to do things, to work on research projects, to run meetings, and they're responsible for doing these things, and they basically need to do it on their own. But I've seen him work with dozens of young scholars who have become very strong professionals because of those opportunities. I think that he gives them more opportunities and more authority than typically Western scholars like us ever would provide to our students. We tend to be more nurturing and softer with our students, and they're stronger. It's a cultural difference, but I think it works extremely well.
Okay, so because we are close toward the end of this panel, we have one last question from the audience from Zoom, and then I think that question request Professor Dota to respond. Could you quickly briefly respond that to that question about, again, I think it is related to the suggestion, okay, for students from the Global South. It's a long question. I don't think you can answer
Yes.
in 1 minute, but then I think you should try.
So Leanne, I will make it short and summarize the question. So basically, the question is, what practical methodologies do you suggest for studying and theorizing about the Global South, from the Global South, and by the Global South? So I will just quickly say, you look at, I'm here in New Zealand, and you look at the movement of Maori and Maori indigenous scholars to build a framework of theorizing, and that's called the Kaupapa Maori movement. And they talk about this idea of Tinoranga Tiratanga, which means sovereignty over how you produce knowledge. So part of the practical suggestion in that sense is to actually build networks of scholars that are doing theorizing that is serious about Asia and the Asian context. Once you build a network, you can build an infrastructure of journals, of conferences, and really create an alternative epistemological structure for intervening into sort of the dominant health communication space.
Yeah, thank you
Thank
for
you.
summarize your 30 years of work into 10-second response. Okay, so we are at the end of panel 2, and then so sorry that we didn't have enough more time for the discussion, but then we greatly thank all the speakers and then the audience being there for us. But then before you leave, can we again take a groovy together, and then we will invite all the participants to turn on your camera if privacy is not a concern. Then we can take a picture together for this panel. Thank you. Three, two, one. One more. 3, 2, 1. Okay, thank you. Thank you very much. Thanks for everyone's coming. Bye-bye. So we'll have our panel 3 in Hong Kong time tomorrow morning, 8:30. So we'll see you there. Bye-bye.
Sleep well, Sandy.
Sleep well, Sandy. And then Terry, you are the person who need to have more, better sleep.
You're
And drink,
right.
lemon water.
Lemon water. Sounds good. Thank you. It was wonderful to see you all.
Yeah, Terry, I hope that, I wish, a good health, because you still have many, services that you need to do.
So true.
And then thank you. And then thanks to other, we have, some other, our invited speakers. They are all, here today, although they are going to do their talks tomorrow, but then they all come here today. They want to learn from others.
We want to see all our friends
to
talk.
other, speakers like Gary, like Evelyn, like, Icha, and then for those people who stay with us. Yeah, thank you. See you tomorrow.
Good night, everybody. Sleep well.
Bye.
Yeah. Wonderful job, Leanne.
Thank you, Terry. And then, if you have time tomorrow, and then if you feel better, please, join us again. Thank you.
Thank you. I will.
Terry,
I do
I'm
teach
Jolie.
tomorrow.
Finally meet you.
Oh, isn't that wonderful? I'm so glad. Thank you.
Thank you. Bye-bye.
Shanghai log out already. Oh, I should thank Shanghai, because he helped us to promote this event to Chinese Communication Association. Such a sweet person. Yeah, but then he just
Isn't
logged
he
out.
wonderful?
I'll thank him tomorrow. Okay,
All
bye
right.
bye. So I will end the meeting now. Okay, bye bye.